Good morning, everyone. I think we're going to get started as we're waiting the residents coming. It is my great honor and privilege to introduce Dr. Edward Stelow from Department of Pathology, University of Virginia. He grew up in our great neighboring state of Wisconsin and went to University of Chicago for his undergrad and then studied medicine in Medical College of Wisconsin. And then came here in 1998. Did a APCP and also the Cytopath Fellowship and the Surgical Path Fellowship. After that, he went to University of Virginia in 2004 and rose to rank to the full professor in 2015. In 2010, he became the Cytopath Fellowship director there. I think Ed is very productive and people call him the paper machine. He has more than 200 publications. And he's a very entertaining and dynamic speaker. He's been lecturing nationally, internationally, and he's especially focused. He's do everything, but he mainly focuses in head, neck, and also gastrointestinal pathology. He's been very active in international societies and also participated in WHO classification of the tumors, and he's been serving as associate editor and also editorial board and a review of many journals. And today he's going to talk about sinonasal carcinoma. It's a very interesting topic. It's not common tumor, but it is a very fascinating tumor to me. Nice welcome.
Thanks. Now I feel a lot of pressure to be really dynamic. We'll see about that. No conflicts of interest? Okay, so I like to go back to the very beginning. I'm an anatomic pathologist. I like to look at things and give them names or call them things. And this is a very human activity. Whether you believe Genesis is the word of God or not, it was at least mentioned by the early Hebrews. One of the first commands that was given to man was to look at things and name them. Now, it can be vexing, as pointed out by Anthony Hecht here in a poem about the naming of the animals. And it can feel sometimes a little bit reductive, like you can't actually name some of the beautiful things that you get to see. Your name doesn't necessarily capture all of the essence of it. That isn't necessarily true with pathology. So as far as naming of tumors go, we couldn't really do it very well until we had histology. And a number of things had to happen for us to have histology. Including just the actual tools for histology, the microscope and the microtome. But then we also had to have a resection, a decent amount of resections of the various tumors at sites for us to actually start naming things. And this really happened and took off in the early 20th century. So here's Dr. Ewing telling us exactly how we're going to name tumors for the next 100 or so years. Histologic, regional, and etiological aspects of them. And here's an example of that with a sinonasal tumor. HPV-related multiphenotypic sinonasal carcinoma. Okay, that's telling us the etiology, it's telling us a little bit about the histology, and it's telling us where it occurs. And you can see they've even changed it because they changed it because of what they thought it looked like. It no longer looked just like adenoid cystic carcinoma to them. I'll show you a picture of that, and it doesn't look perfectly like adenoid cystic carcinoma. So where are we going to be talking about? We're going to be talking about the nasal passages today, and then we're going to talk about the diverticula that come off the nasal passages and grow as we get older, the sinuses, including the maxillary sinuses, where you'll get your squamous cell carcinomas, and then these other sinuses like the ethmoids and sphenoids, neither of which I really knew where they were, I would say, as a resident very well. But this image has helped me a lot. And here's what it looks like from the front. And you can see, I think a big purpose of these sinuses is to give us the looks that we have as an adult, to give us those phenotypes so we don't all have a bunch of baby faces and make us prettier to the opposite sex. Here's what the normal histology looks like. This is in the nasal canal. You can see a lining of epithelium over here. It looks sort of transitional to me. Maybe it's becoming a little squamoid. You have this lamina propria with these seromucinous glands. And then you have some chondroid material under here. So you can imagine you can get tumors of any of these things here. This is what your lining looks like in the sinuses. Nice little columnar ciliated respiratory type epithelium. a little bit of lamina propria, and then bone. So not a lot of room in the sinuses. And then the epithelium can look a little bit more piled up. This is a sort of pseudostratified columnar look. Maybe there's some cilia here, and then it can also have some mucinous metaplasia. This is probably a look more of what people call Schneiderian, although the term Schneiderian doesn't have a lot of meaning. It just came about, supposedly, because Schneider figured out that your snot was actually not coming from your brain. It was actually coming from your mucosa. Yes, that's important. Okay, and so if we look at sinonasal carcinoma, and I'm going to just touch on some of the early stuff here, it's interesting to note that we haven't come that far, although we've sort of subclassified a number of different tumors. And one of the things I want to note here is that Ewing very early recognized that there were carcinomas in the sinonasal tract that look basically like lymphomas. Okay, so these are just undifferentiated carcinomas. Now, undifferentiated carcinomas can occur anywhere, but in the sinonasal tract, they seem to be a little bit more prominent or a little bit more prevalent. And this is one of the first big series that came out about sinonasal malignancies out of the Johns Hopkins. So like I said, you had to collect cases, and taking tumors out of the nose and sinuses, especially big malignant tumors, is not as easy as taking tumors off the breast. So it probably took an extra 15 to 20 years before we started getting larger series of sinonasal tumors than we did of breast tumors. But you can see that already Dr. Geschickter, and I'm going to have a little note about Dr. Geschickter in a second here, was labeling tumors very much like we already see them. He didn't use any of the funny terms like Schneiderian. He actually just called them keratinizing and non-keratinizing squamous cell carcinomas, which is what we pretty much do today. But then he also mentions these lymphoepitheliomas. Now, in his series, he's got a lot of these, and it's probably because he's including nasopharyngeal carcinomas. And you can guess that just by what it looks like when he shows the pictures of the patients with metastases. So from your nasopharynx, when you metastasize, you go back to your level 5 nodes, and you'll get these big nodes in the back of the neck. It's the classic picture of someone with nasopharyngeal carcinoma. That doesn't really happen with sinonasal carcinomas when they're undifferentiated. When those tumors metastasize, because it's actually ectoderm, it'll metastasize in the same pattern as your skin tumors. So typically they'll metastasize out to your parotid early. And just in case you were wondering whether or not anatomic pathologists can live really interesting lives, Dr. Geschickter was pulled in front of the Senate in the 70s because he was part of something called MK Ultra. He was at Johns Hopkins, and at least he seemed to be funneling money to, from the CIA to different programs so they could work on mind control, which never actually worked, but did permanently link anatomic pathology with the X-Files and Stranger Things. Now, the first really big attempt, and best attempt, I think, early on to look at all these sinonasal tumors came from this person named Niles Ringertz. And I've seen this mentioned in a number of different manuscripts as one of the earlier articles about sinonasal pathology. Well, it's not really an article. It's a 350-page monograph that basically has him looking and categorizing every tumor that was seen at the institution, Sabbatsberg Otolaryngological Clinic, and Radiumhemmet in Sweden for over 13 years. The first thing he did was actually summarize all the previous reports and actually use their nomenclature. And you can see Dr. Geschickter's paper that I just showed you is right here. It's one of the bigger ones. But they're using a lot of the same terms that he'll go on to actually use. One of the difficulties with using series of cases from lots of different institutions is not only, first of all, was the histology not well classified, but you do start to see sort of bias at different institutions. And, like I said, sometimes they'll start categorizing nasopharyngeal carcinomas as sinonasal carcinomas. So here's his series itself. And actually, things have not changed much. And at the end, I'll show you what we can pull out of actually his series and where we are today. But basically, there are the undifferentiated carcinomas. There are the squamous cell carcinomas. There are the adenocarcinomas. And then there's salivary gland-type tumors. And there's even the note that basically all of your odontogenic tumors can pooch out from your maxilla into your sinonasal canal. And here's just an image of this, of one of his tumors. What is this? Residence? What would you describe that as? Come on, there's got to be residents here. What? Cribriform. That's adenoid cystic carcinoma up the nose. So tumors still look the same. So in 2017, the WHO met, and this was the list of tumors we thought that were well enough defined that we would name from the sinonasal tract. We're going to go through these, and then I'm also going to show you there's a few more tumors now that seem to be pretty well delineated, that there's a decent amount of push to actually have them given their own type. So squamous cell carcinoma makes up the most common malignancies of the sinonasal tract. This is a little bit different than other areas in the upper airway digestive tract in so much as it's a smaller percentage of the overall tumors at that site, but it's still the highest. The incidence rate is very low. It's a little more common in men, probably secondary to different exposure rates to all the different chemicals and work patterns that people have. The tumors, squamous cell carcinomas occur often within the maxillary sinus. It's going to be a little bit different with some of the other tumors. Whether or not they can get the tumor out and how localized it is tends to depend on where it is. As you can imagine, a tumor that presents in your nostril and grows there, you're going to notice before something is growing, before you're going to notice something growing in your maxillary sinus. Excuse me. It's really dry here compared to Virginia. So what are the risk factors for squamous cell carcinoma? Smoking. So it's actually the incident rate has fallen because the incident rate of smoking has fallen. Exposures, including wood dust exposures, which all of us know is the main risk for intestinal-type adenocarcinoma, which we'll talk about in a little bit. Formaldehyde is constantly listed as a risk. So when any of you ever get sinonasal carcinoma, I imagine you can sue the chairman of where you used to work. High-risk human papillomavirus turns out to be a major risk factor. We'll talk a little bit about that. And then a lesser risk factor are Schneiderian papillomas. They can eventually become malignant, and I'll show you some pictures of that. So as I mentioned, the incident rate is falling, probably because exposure rates and because smoking rates are falling. The death rate is falling just a tiny bit, but like all head and neck cancers, aside from those secondary to HPV, we're not necessarily curing them at any higher rate than we were in the early 70s and 80s. What we've mostly modified as far as that goes is just morbidity. So a lot of the procedures that we do or that our otolaryngologists do are much less morbid than they were 20 or 30 years ago. 5-year survival rates, typically between, well, it looks like about 30 and 40% there, depending on whether or not the tumor's, what stage the tumor's at. And like I said, that's been pretty constant over the years. As far as high-risk HPV goes, people have looked at this, and it seems to be a little bit related to the phenotype of the tumors, just like it is in the oropharynx, but you can see it stretches over basically all the phenotypes. Almost half of the tumors that are non-keratinizing squamous cell carcinomas up there are related to high-risk HPV, much fewer of the keratinizing squamous cell carcinomas. And then all these funny little variants we like to talk about squamous cell carcinomas. And then we're going to hit on these at the end too. Some of the neuroendocrine carcinomas and undifferentiated carcinomas are related to it. In 2017 at the WHO, it was thought that we only should report HPV status for the oropharynx because that was the only site that showed an obvious difference in overall outcomes for the tumors. This is one series you can see where you can see that the HPV tumors are pulling away, at least for a while, from the non-HPV tumors. Here's another series, again, where they weren't able to show statistical significance, but I certainly think it's suggestive. And I reviewed another paper recently that actually did show a statistical difference. So I think we will be reporting HPV status with sinonasal carcinomas, if anything, just because of the overall prognosis, although it may allow for different treatment modalities eventually. Here's all the morphologies that one can see with these tumors. Here's the regular old non-keratinizing squamous cell carcinoma. Here's a more papillary exophytic tumor. These tend to have like surface that look like high-grade squamous intraepithelial lesions of the cervix, another high-risk HPV-related lesion. They can be very difficult to tell whether or not they're truly invasive, so we typically don't even try. The tumors can be undifferentiated and look similar somewhat to a nasopharyngeal carcinoma, and they seem to pull a bunch of lymphocytes with them, just like the other EBV-driven tumors of the nasopharynx. And then sometimes they can even be somewhat glandular. So they can basically almost have any phenotype. And that's going to be a recurring theme up the nose. The use of P16 probably isn't as helpful up the nose because the actual HPV rate is quite a bit lower. So in the oropharynx, where you have an HPV rate of about 80%, P16 is a good surrogate marker. When you get out of that range, it tends to become a less robust surrogate marker. You can see it really is not as helpful for tumors that are keratinizing. It tends to be a little bit more helpful with the actual non-keratinizing tumors, but not good enough. And here's just an example. Here's a very funny looking tumor we had from someone's nasal canal that even had somewhat of a spindled cell component. That's the block-like P16 positivity that you get when something's actually knocked out retinoblastoma, instead of that more mosaic pattern that you'll see when someone actually has wild-type pattern P16 expression. And then there, of course, with a lot of squamous cell carcinomas of the upper aerodigestive tract, you actually get P16 knocked out, often through promoter methylation. So in those cases, you'll actually just have a P16 negative tumor. And there's a high-risk HPV DNA probe that we used to use. That's nicely positive in that case. So a small percentage of sinonasal papillomas eventually become malignant. Interestingly, as far as sinonasal papillomas go, there seems to be two ways that they occur. One is through a driver mutation of EGFR. It's a different mutation than any of the ones that you see for your lung cancers. And one is through a low-risk HPV. And it might be that they look a little different, although I've never really tried to separate them. But low-risk HPV is probably between 10 and 20% of the cases of sinonasal papilloma. And for some reason, it seems to be those cases that are at risk, or at most risk, for eventually becoming squamous cell carcinomas. And here's just a case we had somewhat recently, and we had put in a manuscript. This is the papilloma over here. I think you can see that it looks like all the nuclei look pretty small. There's little brown dots here. That's the HPV, high-risk HPV RNA. And then here's the more malignant tumor over here. It was actually a poorly differentiated squamous cell carcinoma with huge nuclei, anosonucleosis, and it's also low-risk HPV positive. So we don't know how low-risk HPV drives those tumors, whether it just is a carry-on. I imagine it drives them somewhat. If anything, it just induces a proliferation. All right, moving on to adenocarcinomas. So that we separate these into intestinal and non-intestinal variants. That's a very easy morphologic break for us to make. And then there's all those salivary gland tumors. I remember I showed you those seromucinous glands. So not surprisingly, you get a decent number of salivary gland tumors up the nose. Intestinal-type adenocarcinomas are much more common in men, and this is the one that's related to heavy hardwood dust exposures. So this hardwood dust puts you at about a 20 times risk for squamous cell carcinoma of the nose. That's about the same as having a big smoking history and your risk for lung cancer. However, it puts you at over 1,000 times risk for the development of intestinal-type adenocarcinomas. And I hadn't seen this before, but we actually just had a recent case at UVA of two brothers who spent their entire lives making barrels, who both got intestinal-type adenocarcinomas of the nose. It's sort of interesting. But you can see other dust exposures also put you at risk. Again, formaldehyde puts you at risk. These tumors don't usually present with lymph node metastases. They're usually localized when they present at diagnosis. 5-year survival is somewhat similar to squamous cell carcinoma with about a 50% survival, although these are high-grade malignancies. This has a nice story to it. An otolaryngologist in England recognized this, Esme Hadfield, and there's even like a little movie about her that they made for epidemiology students. That's about 20 minutes long. She recognized that a good number of the people in the furniture industry were getting these tumors in England. And this isn't really disrespectful that they're calling her Miss. That's just how they refer to each other as when they're doctors, and at least back then. Here's the only picture you can see of her on the internet. And you can see she's actually participating in one of the bigger risk factors for sinonasal carcinoma. She was supposed to be very tough. And here's just what this looks like. It looks like an intestinal-type adenocarcinoma. Most of these tumors, or many of these tumors, are more papillary and exophytic. They look somewhat like a tubular adenoma. Sometimes they can be invasive and mucinous, just like adenocarcinomas of the colon. Unlike in your colon, however, these are almost never related to MMR deficiency. And then sometimes they can actually even get a signet ring morphology. You can see here again, this is just the prognosis. These are high-grade malignancies. They tend to eventually kill the patients. As far as grading goes, there are a lot of papers that came out in the 1980s about grading these tumors, with the papillary tumors on one side and sort of the more undifferentiated and signet ring tumors on the other side. They're so uncommon that I tend not to grade them. Although you can imagine some of the more exophytic papillary tumors do better than the more poorly differentiated, more infiltrating tumors. And this, I'm only going to put up one note of this. So it's certainly been a movement within the otolaryngologist community to move toward endoscopic resection of tumors rather than craniofacial resections, which are much more morbid. But you can see here, so you lose the morbidity early on with these tumors, but they tend to do worse. So the craniofacial resections seem to do worse or do a little bit better in the long run. As far as non-intestinal type adenocarcinomas, these are sort of a potpourri of tumors. And I'm going to show you just some pictures of these. We just call them low-grade and high-grade. And the reason we distinguish these is because the low-grade ones almost aren't even tumor or almost aren't even malignancies. They have a risk for recurrence, but they never actually kill the patients. And here's a picture of a nice, pretty little low-grade one. This one is somewhat papillary. It's even making some little calcifications here. Looks a little bit synomatous. We are starting to pick tumors out of this that have unique genetic signatures. So some of the low-grade tumors have been shown to have ETV6 NTRK translocation, similar to what you see in a mammary analog secretory carcinoma, although they don't really look like mammary analog secretory carcinoma, which, just for all the non-anatomic pathologists, is a tumor of the salivary glands. And here's a picture of what those tumors look like. And you can see they don't look very much different than the tumor I already showed you. They have a little bit more of a tubular pattern. All the tumors I've looked at that have a more tubular pattern like this. None of them have had an ETV6 translocation. So this is just one of the patterns of low-grade adenocarcinomas. And then high-grade adenocarcinomas can have a bunch of different looks. We call them high-grade because they're associated with nuclear atypia, mitotic figures, necrosis. They behave much more like intestinal-type adenocarcinomas, so they're high-grade malignancies. Here's one. Here's another. You can see they look quite different. They're probably different groups of tumors, but they're so uncommon we don't have a way of organizing yet these tumors. This looks sort of apocrine, although it didn't mark with any salivary duct carcinoma markers. Here's a funny one growing out of a more oncocytic type papilloma. It's got a mucoepidermoid look to it, although it didn't have any mammal-2 translocations. And then here's a recent tumor we had that's just been reported that we called adenocarcinoma, but we mentioned that this stuff right here, all this reticulated stuff, actually had very nice staining for Hep-R and glypican-3. Okay, so this is yolk sac differentiation in a high-grade carcinoma. As it turns out, these yolk sac-driven adenocarcinomas are not similar really to germ cell tumors. They're much more similar to the carcinomas, and it's been shown that these tumors are INI1 negative. So we had this case a few years ago. I remembered it when the paper came out, and I pulled the slides, asked for some recuts from Kansas. They sent it to us, and basically it showed itself to be INI1 negative, just like it was supposed to. Unfortunately, we were not the ones that figured that out. And then here's a tumor, an adenocarcinoma up the nose that we just called high-grade adenocarcinoma that, that turned out to be high-risk HPV positive. Okay, so that's also playing a role in some of these high-grade adenocarcinomas. Salivary gland tumors have to be typed, so anytime you approach an adenocarcinoma of the sinonasal tract, if you don't immediately recognize it as intestinal type, you have to think to yourself, is there any way this is a salivary gland tumor that I can better categorize it as? This is an early series with data from the AFIP by Gnep And he showed that basically mucoepidermoid carcinomas and adenoid cystic carcinomas were the most common malignancies that you would see up the nose. And this is a more recent series from Memorial Sloan. These are their sinonasal malignancies right here. And you can see that the most prevalent type of adenocarcinoma is going to be adenoid cystic carcinoma. Then they also had some mucoeps. And then they had some sort of others. And what did they called something just adenocarcinoma? I have no idea what that means. But you can see that the most common is still adenoid cystic carcinoma. Here's the sinonasal carcinoma that we saw that had a salivary gland phenotype. It's a little more solid down here. There's more nests of clear cells up here. Here it is up beneath the epithelium. You can see that there's these big nests of clear cells. Okay, this is a salivary gland tumor. What translocation is it going to have residence? What does hyalinizing clear cell have? EWS, ATF1. So it's just, so I mean, as it turns out, clear cells, for whatever reason, when they have a lot of glycogen, like this is true even with Ewing's sarcomas, they seem to be related to the EWS translocation. We don't necessarily know why that's the case, but when people used to try to figure out if something was a Ewing's, they would actually do things like a PAS stain to see if they had glycogen in them. We don't do that anymore, but this tumor also makes glycogen, although it has a much better prognosis than a typical Ewing's. Here's a higher grade area. So a lot of your salivary gland tumors can undergo high-grade transformation. We speculated that that's what happened with this tumor. This tumor had an EWS translocation that we were able to show by FISH, but then it also had areas that really weren't within the realm of what typically looked like hyalinizing clear cell carcinoma. And this is another tumor. So this is a tumor that was just called SNUC. This was the biopsy of it. This is just a poorly differentiated, undifferentiated type carcinoma with big open chromatin. Okay, but this turned out to just be a dedifferentiated adenoid cystic carcinoma, and they figured that one out when it actually came out. Once it gets this pattern of growth, it might not matter what the original driving tumor was. This person probably will die of metastatic disease rather of the more indolent sort of progression of a typical adenoid cystic carcinoma. As far as salivary gland tumors go, there is now an HPV-related tumor that seems to show seromucinous differentiation. This is that tumor that I showed you in the beginning, this HPV-related multiphenotypic sinonasal carcinoma. These occur over a broad age range, more common in women. Interestingly, a majority of these are related to HPV type 33, somewhat strangely. I don't know if that type of HPV has a little bit more of a tropism toward the seromucinous glands, but the tumors seem to be showing a seromucinous differentiation. And this actually really messed up the literature at first because we knew adenoid cystic was a translocation-based tumor, but we couldn't figure out why every now and then people would say adenoid cystic carcinoma was related to high-risk HPV. And that's because some of these tumors up the nose that have a little bit of an adenoid cystic look were actually turning out to be related to high-risk HPV. Although they don't recur in the aggressive fashion that adenoid cystic carcinomas do, and there's really been no deaths reported related to these tumors. So it's important to distinguish this from something like a true adenoid cystic carcinoma. Here's an image of this. You can see it doesn't necessarily look like an adenoid cystic carcinoma. That's why they've changed the name to multiphenotypic. To my mind, it looks more like a malignant mixed tumor. In this tumor, the epithelium looks intact and not involved. And then you have this, obviously, these very cellular and less cellular areas of tumor. You do get this sort of basophilic stuff being put down with these little tiny microcysts. I think that's why they thought it looked like adenoid cystic carcinoma, although they really don't look like the cylinders that are put down in a typical adenoid cystic carcinoma. And then, unlike a regular adenoid cystic carcinoma, these can be associated with overlying squamous atypia, sort of a funny looking dysplasia there, and even maybe some squamous cell carcinoma right there. So it's important to distinguish those because those have a really nice prognosis. Neuroendocrine carcinomas occur up the nose. If you see anything that looks like a carcinoid tumor or even an atypical carcinoid tumor, the best thing to do is probably talk to your neuropathologist and make sure they're not pituitary adenomas or ectopic pituitary adenomas, which I think the majority of them turn out to be. Most of the tumors we see that are not pituitary are high-grade malignancies, either small cell or large cell neuroendocrine carcinomas, a quarter to a half of which are related to HPV. When HPV seems to be involved with the development of high-grade neuroendocrine carcinomas, it doesn't seem to carry the good prognosis or the better prognosis it does with squamous cell carcinomas for some reason. You really can't use P16 in these cases because remember, high-grade neuroendocrine carcinomas are often knocked out at retinoblastoma already. That's one of the ways you can make a high-grade neuroendocrine carcinoma if you have a laboratory where you're making tumors. So the P16 will pick them up and it's not a predictor of actual HPV. So they can be small cell, large cell, or kind of a mixed pattern. I tend to be a little bit more liberal in my use of the term small cell carcinoma than some of my colleagues who will call a lot of things large cell neuroendocrine carcinomas, give us a higher rate of large cell neuroendocrine carcinomas in the lung than most institutions seem to have. These occur in older patients. Most of them are already stage 4 disease. Small cell carcinomas, remember, metastasize early. Again, with the 5-year survival, although they also will kill the patients. And here's an example of one that we somewhat recently saw. This was in a 40-year-old woman. This case is made even more interesting by the fact that I just saw her liver metastasis biopsied about 2 years after, just a couple weeks ago. You can see there's a bunch of apoptotic bodies here. There's increased mitotic figures. I mean, there's a little bit of nuclear size increase, right? So some people might not want to call this small cell carcinoma. Although I would contend in the lung, when you actually resect small cell carcinomas, the cells look bigger than they do on typical biopsies and what people are used to calling small cells. Here's a P16 stain, nice block positive, but like I said, it's probably not that useful. And here's the RNA fish, or ISH, and it's nicely positive. It is important to distinguish the grade 1 and grade 2 tumors. They do much better, but again, I think most of these are probably pituitary adenomas. Now, moving on to undifferentiated carcinomas. So there's the waste paper basket now of sinonasal undifferentiated carcinoma, and then there's a number of these other carcinomas that we've sort of picked off that we know a little bit about the etiology of. We'll go through here. As far as SNUC goes, I told you that undifferentiated carcinomas were described early on, even by Ewing recognized them. Basically, they were lymphoepithelioma-like without the lymphocytes. There was an early series, once immunohistochemistry started being used in the 80s, that delineated a nice group of these at the University of Virginia. We have a lot of these tumors at the University of Virginia over the year because we had a very active craniofacial resection group. These are tumors that occur throughout the sinonasal tract. Most of them present at high stage. They have a little bit worse 5 years survival than squamous cell carcinomas and adenocarcinomas, and they have a much worse prognosis than some of the other blue cell or bluish cell tumors. Although I don't think they overlap very much, it was important to distinguish that these tumors are not some kind of olfactory neuroblastomas. These are just really bad carcinomas. And then recently it's been shown that these tumors frequently have isocitrate dehydrogenase mutations that seem to somehow be driving them. And it's thought now with that there might be some targeted therapy available potentially for these patients. Here's just the survival curves. You can see that these tumors do very poorly no matter what is done for them. And here's just an example. It's basically a diagnosis of exclusion now. So I see a tumor like this. I don't really see any differentiation. You might wonder if it's trying to show a little bit of squamous differentiation there. I don't know. It's just maturing slightly bit. It's got a little bit more cytoplasm. But it really this tumor would have to really not mark for any of the other markers. And in today's world, I'd have to show that it can't fall into any of the other categories of tumors that we're about to describe. Another tumor that actually looks quite a bit different. This looks, in some ways, this looks like the sheets of cells you might see with a nasopharyngeal carcinoma with the big open chromatin and the prominent cherry red nucleoli, though the lymphocytes aren't there. But this was also called SNUC at our institution. Okay, now moving to the tumors that have gotten pulled out of SNUC over the past 10 or 15 years. So nut carcinoma, or what used to be called just a few years ago nut midline carcinoma, then someone said, oh, not all the tumors are midline, so now it's just called nut carcinoma. That's how the naming goes in pathology, the vexing naming of the tumors. So these tumors were originally reported in children, not surprisingly, because they're the only They're the only people that are going to have their carcinomas karyotyped. If you try to send your carcinomas to get karyotyped, at least in my experience, and it's been my experience ever since 17 years ago, getting calls from Michelle Dolan saying, you really don't want me to have to karyotype this carcinoma, do you? Because carcinomas tend to have very complex karyotypes, and they don't like having to karyotype them. So they get canceled. But it was first recognized in children. We ended up looking at some cases eventually, let's see here, of the upper aerodigestive tract that we had called SNUC, and we found actually that 5 of the 30 cases that we had material on were actually not carcinomas, and it really broadened the age range. We had up to an 80-year-old or so that had actually one of these malignancies. Most of the time you can test for this, or most of the older literature tests for this using in situ hybridization or FISH, looking for a break of the nut. But in today's world, a lot of us use immunohistochemistry. The antibody has been shown to be pretty decent. Tumors occur over a wide age range. Like I said, we had the oldest patient. They occur equally in men and women. And you can see that most of the tumors still do occur in the mediastinum and sort of thorax, although a significant portion of them occur in the head and neck. What do these look like? They have sheets of undifferentiated shells. I'll show you pictures of that. Sometimes they can start to look a little bit more squamoid and look a little bit more nested and be surrounded by desmoplasia. I'll show you a picture of that too. It's been noted that by some that these tend to look somewhat uniform, the nuclei, compared to a typical carcinoma. It may be because these tumors actually have a much more simple karyotype, that we don't see all the nuclear atypia, although I don't usually use that as a feature to decide whether or not I'm going to work the tumor up for that disease. They're high-grade tumors. Squamous differentiation is often seen with these tumors, and it can be very abrupt. I know Dr. French came here a long time ago, or at least a while ago, and spoke at the University of Minnesota. I'm assuming he showed pictures of this, but I'm going to show pictures again. A case has been described in the parotid, at least, that showed some mesenchymal differentiation. So here's a nice case we had. This case was actually turned out to be in the larynx. Here's a sort of squamous reactive epithelium over the top of it, and then it just looks like a big sheet of undifferentiated cells underneath it here. I think your differential diagnosis would have to be lymphoma. Here's the P63 immunohistochemistry, so you can see just by that they're showing some squamous differentiation. You can see the basal nuclei of the normal squamous epithelium or the metaplastic squamous epithelium up here, non-neoplastic, and the tumor both staining strongly. Here's a higher power image. Like I said, some people think these are a little bit more monomorphic than you typically see with a carcinoma that's developed outside of the translocation method. Here's a variant that looked, here's another case that looked with the desmoplasia that looks a little bit more squamoid to me. You can see the nuclei lining up, and then they stream on the inside. The streaming is usually a feature I associate with squamoid differentiation. And then here's this abrupt squamous differentiation where you have groups of undifferentiated cells right next to this very differentiated, obviously keratinizing squamous material. And I'll talk a little bit about that in a second. Here's just an example of the break apart fish. So these tumors are just defined basically. They have to have the actual nut rearrangement. It can have a number of different partners, most commonly bromodomain 4 or BRD4. However, because of all the different partners it can have, we use a break apart probe to look for it. It's actually believed that the fusion protein somehow stops differentiation. So when they've actually induced withdrawal of the fusion protein, what happens is all their undifferentiated cells will become differentiated. So it's very much, I think, like a promyelocytic leukemia or something, where you can actually induce differentiation in these tumors. And it's thought then that maybe targeted therapy may help may help these patients, although I don't think it's been shown to be that helpful yet. Survival is terrible for these tumors, especially if you happen to be over 18 when you get them. Right? So you just fall off and you die within less than a year. So these are worse than a typical sinonasal undifferentiated carcinoma. Little kids do better. That's probably just because you can treat them so much harder. INI-deficient carcinomas have recently been recognized. At first I argued a little bit against trying to define tumors based on what tumor suppressors they were missing. We don't do that with P53, obviously, one of the first tumor suppressors that we really recognize as being damaged in so many tumors. However, INI1-deficient carcinomas or INI1-deficient tumors do seem to have a relatively unique phenotype, and it's certainly true that at other sites of the body, including in the soft tissue, INI-deficient tumors do end up with their own names. So I think and now also we have at least potentially some targeted therapy for these patients. So there's been a move to classify tumors that are INI1 deficient as INI1 deficient carcinomas. These occur in men and women over a wide age range, and of course can occur anywhere throughout the sinonasal tract. Interestingly, they're much less common. A lot of these tumors, even though they're occurring here, are much, much less common anywhere else in the upper air digestive tract, though. They don't really occur in the nasopharynx. You don't see them in the mouth. You don't see them really in the larynx very often. Like I said, most of these are probably called SNUC. I'll show you what they look like. Some of them are called non-keratinizing squamous cell carcinomas. They can even look a little bit myoepithelial. I showed you that picture of that adenocarcinoma before that had yolk sac differentiation, so there was there were some tumors in that. They tend to, at least half of them or so, have a very obvious rhabdoid or plasmacytoid morphology. Tumors are, for the most part, keratin positive with variable P63 positive and endocrine expressions. Recently, there's been series showing that other portions of the SWE/SNF complex that's related to the chromatin remodeling. So other proteins that make up this big complex with INI1, like SMARCA4, can be lost in some tumors. I just read a paper having a series about 9 or 10 of those. For some reason, they show a little bit more of a neuroendocrine phenotype. And here's what it looks like. This is a nice case showing the more rhabdoid phenotype. Okay, big pink cells. So they say there's two types of them. There's big pink cells and big blue cells. Here are the pink cells. Here's a little bit more of the blue cells. This one looks like it's trying to almost make abortive glands. This one looks much more squamoid. Okay, this one I think we actually originally categorized as a non-keratinizing squamous cell carcinoma. This one looks this one got categorized as myoepithelial because it has this clear cell phenotype, and it was P63 positive. But it turned out to be another one of these tumors. As far as HPV goes, it can also induce an undifferentiated phenotype, or it can be present in undifferentiated tumors. Here's two different series looking at large groups of sinonasal carcinomas, and you can see that a small portion of their actual SNUCs, or what they had called SNUC, turned out to be high-risk HPV positive. Just something to be aware of. So if you look at overall what we've done to SNUC, or what we've done to the very early idea or point of viewing that there's undifferentiated carcinomas in the sinonasal tract, it seems to be especially prone to them, we've sort of pulled them out, pulled them apart based on their etiology. Usually their molecular etiology, but sometimes also their infectious etiology. So you have both EBV and high-risk HPV that can cause tumors. You have the nut carcinomas. You have the INI or other members of the SWE/SNF complex being lost. You have like some of these dedifferentiated salivary gland tumors. And then we've gotten a little better at distinguishing some neuroendocrine carcinomas with immunohistochemistry. So, going back then to the early group of tumors that I showed you from Sweden, what we've done is we've pulled the squamous cell carcinomas a little bit apart. We have the not otherwise specified types and all their variants, including like verrucous carcinoma and everything. But then we're going to, like I said, I think we'll soon have to point out whether or not those tumors are related to high-risk HPV, because they do have a better prognosis. We have the nut carcinomas that we're pulling out. Those have a much worse prognosis, and they are offering targeted therapy. At least they were at the Brigham for a while. And then the INI1-deficient carcinomas that can also get pulled out of the squamous cell carcinoma group. Again, because of the targeted therapy, that might be important. The adenocarcinomas, we've pulled those apart based on phenotype, and then a little bit of some genetics, and then also etiology. So the intestinal-type, basically the phenotype, and related to wood dust exposure. Then we have the low-grade and high-grade ones not otherwise specified. I think we're going to start to pull some of the low-grade ones apart based on their etiology. And some of the high-grade ones we're going to pull apart because of their etiology, either because of high-risk HPV or other molecular abnormalities like INI1 deficiency. As far as the undifferentiated tumors go, we still have probably a little bit, about 50–60% of the tumors still fall into this sort of waste paper basket of sinonasal undifferentiated carcinomas. Then we're pulling them out based on etiology, either because of virus etiology or because of molecular etiologies, including molecular etiologies associated with salivary gland tumors. And then we have really worked in the past 10–20 years. We've gotten much better at distinguishing salivary gland tumors, as we've come to recognize that many of them have very prototypical and recurrent cytogenetic abnormalities. And then I also mentioned that one tumor that you have to be aware of is that HPV-related multiphenotypic sinonasal carcinoma that has a very, very good prognosis. So in conclusion, sinonasal carcinomas are extremely heterogeneous. High-risk HPV plays a role in many of these tumors. I do think it will have some significance for prognosis, at least with the straight-out squamous cell carcinomas. We still are, I didn't talk very much about this, we still wonder about how much neuroendocrine differentiation something can have before we flat-out call it a neuroendocrine carcinoma up there. Certainly typical small cell, something that looks like a small cell carcinoma, I'll call. But other tumors can have neuroendocrine differentiation. We don't call them neuroendocrine carcinomas necessarily. So still some of the tumors are a little bit dirty. Certainly the non-intestinal snacks or sinonasal adenocarcinomas are extremely rare, and the phenotypes are all over the place. I'm sure we'll figure out eventually that they have different molecular etiologies. And like I said before, SNUCs, still probably more than half of them remain to be are within a garbage can. Although I will say that isocitrate dehydrogenase is actually probably takes up 60 to 80% of the cases, is probably going to actually help to actually really define those tumors. And that's it. I can take questions. People can come up here and ask me questions, whatever you guys want to do. Or you guys can just take off. Yeah.
SNUCs that have this IDH mutations, do they have P53 abnormalities?
I mean, I don't remember if Vicky, Joe, some of them do. Like certainly, like originally, a decent percentage of SNUCs showed P53 abnormalities, enough that I would expect that there's an overlap with the IDH. I know that data's got to be in that paper by Vicky Joe, because they did widespread, or they did a large genomic panel on them, but I don't remember. Yeah.
You haven't mentioned EBV at all. Does it play any role in maybe other ethnic groups?
So in other ethnic groups, well, the biggest role EBV plays in the sinonasal tract is with NK T-cell lymphomas. It doesn't play very high role or very much of a role with the sinonasal carcinomas, unlike the nasopharyngeal carcinomas. Are the sinonasal ones that we do see more population-based, just like nasopharyngeal carcinomas? There's so few of them. I imagine they are, but I don't know for sure. Yeah?
So for most of these markers, INI1 or not, you can also do it by immunohistochemistry. Do you have a preference actually for fish? And you test for all of them by fish, or?
No, so I do immunohistochemistry on a lot of them. I mean, I usually follow up because nuts are uncommon enough, and because we brought up the fish, I'll usually follow up the immunohistochemistry with the fish, so I have nice examples. We don't do any INI1 located fish. We just always do immunohistochemistry. Same thing for SMARCA4 and stuff. So we use mostly immunohistochemistry. For more of the uncommon translocations, we're using all fish, though. For almost all of our salivary gland translocations and stuff, we don't use the MIB antibody for adenoid cystic carcinoma. We use the fish. So.
And another question that I have, I mean, it was an excellent overview. Thank you very much for this. There is a group of, especially sarcomas like rhabdomyosarcomas, that create a lot of confusion because they can tend to express some of the markers of carcinoma cells, like neuroendocrine markers, for example. So alveolar rhabdomyosarcoma is known to do that. Do you have any experience with this?
Well, so we were talking this morning, the adenoma-like Ewing's is probably the best example of something that looks like a carcinoma that, but at least for now, is being considered a sarcoma. I've looked for adenoma-like Ewing's, and I haven't been able to find them in our files. I assume at one time we saw something that was very cytokeratin positive and called carcinoma, even though it was a Ewing's. Certainly you have, I mean, you hope that when you do your panel on a small blue cell tumor, you'll capture your rhabdomyosarcomas. I mean, so you hopefully you're doing a Desmond or something. And then another tumor up there that you can even get that I have seen is DSRT, which is again going to express cytokeratins. I'm not aware of us miscalling a rhabdomyosarcoma a carcinoma. My experience, the keratin's a little more limited, yeah. Yeah. I never do neuroendocrine markers really without doing keratins, I'll say that. I don't like doing that. My colleagues will do that, but I like to always have a keratin positivity before I call something neuroendocrine carcinoma. I mean, they don't do it. I ask them why they don't do it, and they say they're trying to save the patient money. I really don't think we're saving the patient very much money in their overall healthcare costs based on doing a keratin immunostain or not. So I don't get it. But I'll do it with neuroendocrine carcinomas. I always do it.
It's a nice picture you show. So just a question for the sinonasal tumor. If it's a low-grade molecular testing is mainly for academic interest, right? But the high-grade, if you can't classify, probably you are obligated to do molecular and also.
So with a high-grade are you talking about adenocarcinomas?
Even the adenos, because they can be INI1-Deficient or
Right. Yeah, so I mean the low-grade tumors tend to be sort of just those low-grade funny-looking adenocarcinomas. And right, it's just all academic.
Yeah.
There's nothing, they're not going to recur really. I mean, they recur a little bit, but they're not going to kill the patient. They're not going to ever get chemotherapy, hopefully, or anything. So, yeah, it's just for my own. Well, like I said in the beginning, we're naming people. We like to look at things.
Yeah, yeah.
Naming beings, I like to do that. So, in those cases, I don't charge the patient. So.
Okay. Questions?
I found the association with hard wood interesting because it's very specific exposure. Do you know more about that? I guess
Why it's hardwood and not softwood? I mean, they've done the same studies, so those studies have been very robust in some parts of the world. For some reason, they're less robust in other parts of the world. So I do know we've tried to do those studies in the furniture industry throughout the southeastern United States and stuff, and yeah, but they're not as robust. Yeah, I mean, and also furniture is hardwood. Yeah, so no, I don't know. I mean, if you've ever worked with sawdust.
formaldehyde in the preparation of the furniture? Have you looked at that?
No, I don't know. I don't know if there's anything to do with specific preparations. Maybe just the way the English do their work. I don't know. Maybe their noses are different size. I mean, if you've ever worked with sawdust, I've been amazed, like 2 days later, you'll have this nasty brown stuff coming out of your nose that's filled with sawdust. So you do see why it gets up there and it gets trapped. But I don't know why. It seems to be some populations it's more robust, and why specifically that would.
Yeah, I think that's interesting. And right, it could be a physical phenomenon where you get inflammation.
Yeah.
Result in inflammation.
Yeah. I mean, people have tried to even show that early on you'll get intestinal metaplasia. There's a couple not very great studies showing that intestinal metaplasia can occur early on in patients, and that might be the precursor that eventually gets them to this point. I mean, sinonasal pathology is very interesting because for whatever reasons, the epithelial precursors in the nose seem to be very plastic. So you can see so much different differentiation that you don't see at other sites.